Okay. So, hello, everybody. Welcome to this scientific series. I have the pleasure to introduce Dr. Dounia Rouabhia. Yeah. Dr. Dounia Rouabhia is an internist geriatrician with particular expertise in cardiogeriatrics, frailty, and nutrition in older adults. She completed her Doctor of Medicine at Université Laval, followed by a residency in internal medicine and subspecialty training in geriatrics. Dr. Rouabhia also holds a Master of Science in Clinical and Biomedical Sciences with research focused on frailty screening and risk assessment in older adults undergoing intervention cardiology procedures. She completed a postdoctoral fellowship at McGill University examining frailty, nutritional interventions, and physical exercise in older adults. She's currently completing a certificate in education and leadership in health profession at University College London in the UK. So welcome. We are very excited to have you.
Thank you. Hello, everyone. Thank you again for the invitation to talk to you today. So we're going to talk about sarcopenia, malnutrition, in the GLP-1 era. And I called it hell of food because you're going to see throughout the talk that we need to be aware of what's going on with this particular medication, was particularly popular and sexy, trendy right now. If you are a clinician, a researcher, it's still a very, very hot topic, I would say. Okay, so let's see if I'm able to switch. There you go. Okay, so I have no conflict of interest regarding today's topic. And the learning objective, if you want to sit, there's two seats here, right here. Don't worry about it. Comments. There's no.
Don't be shy.
Don't worry. Yeah, don't be shy. All right. So the learning objectives today were you've read them at on the poster, but I scrunched it up into three main questions that I'm gonna try to answer for you guys today. So what are GLP-1 agonists? What is sarcopenia? What is malnutrition? And why is it important? What should be important to us, and why we should be mindful of when we think about GLP-1s, and what we can do about these different topics, and that you will see this different aspects of it. So throughout the talk, there's going to be this little case. Mrs. Ozempic, 82 years old. She lives alone. Is a classic geriatric patient. She lives on the third floor of an elevator building. Her weight is 72 kilos right now, but in the last 6 months, she lost around 4 kilos. So 5% of her body weight. And she's a classic older lady with type 2 diabetes, with heart failure, hypertension, and her kidneys are not top, but she's still, doing her thing, and osteoporosis. And her husband sadly passed away about 8 months ago. And since then, she's more of a tea and toast kind of lady, not much appetite since, hence probably the weight loss in the last 6 months. And she fell once. She's telling you, I'm not using the stairs anymore, no fractures, but I walk with a cane, and I kind of avoid stairs now. We're going to talk about grip strength later, but she has a 16.5 kilos on the right hand. You'll see what it means a bit later. In her medication, for those here who are not clinicians, she's got the classic medication for diabetes, classic medication for heart failure, and something for her stomach, and something for the osteoporosis. So when you look at that, as a clinician, you receive a consultation from one colleague. I'm not going to name specialties, but they tell you she's got a BMI of 31. She's got heart failure and diabetes. What's your opinion on starting semaglutide? Thank you, from the colleague. So the first questions I want you to think about, it's more of a rhetorical question and going to follow us during the talk, is who screens for sarcopenia before signing this prescription? Who adjusts insulin if her appetite drops further? Who assesses body composition at follow-up? Who looks at that when you start a medication like semaglutide will, so there's going to be a significant weight loss. So when we talk about GLP-1 receptor agonists, so for it's easier to say GLP-1, so you're going to hear me saying GLP-1 throughout the talk. Interestingly, the first version of a GLP-1 was approved in 2005, and it was extracted from a protein in the Gila monster venom that you can see here, which is this sexy beast right there. And then with the studies, it took a bit more time until 2010 before the first long-acting analogs like the liraglutide were approved, and then the famous semaglutide in 2001. And since then, so I put this slide here just to give you an idea. There's a lot of them out there, and I have no commercial interest, so that's why I put everything right there. So there's new version every day, and then the oral version is starting to come out, and now so it's going to be even more, even easier to have access to that, because right now the one that you see on the slide are more of a injection format. So it's a big family of medication to, yes, lose weight, but it was first developed for diabetes, as I'm going to talk a bit about that later. So in terms of prescription, there was an interesting study that looked at the prescription of GLP-1 from 2011 all the way to 2021, and we see around 2 million prescriptions in the US with an exponential in use, especially in older adults. In Sweden, we see the prevalence go from 4 to 17 patients per 1,000 inhabitants. And the surge of GLP-1 prescription for obesity, it's more than 500% increase in prescription. And the indication of this medication started from diabetes, very efficient for diabetes. Then obesity, because we saw that people were losing a lot of weight with that. And now it's like the miracle drug for kidney disease, for heart failure, for liver disease. Should we put it in the water, in the city water? Maybe. We'll see at the end of all of that. And who accumulates all those comorbidities, like I said, obesity, diabetes, heart failure, usually older adults, because we have these comorbidities arriving with age. And the main question is actually who received the patient that we prescribe it to in the real world, how do they compare to the ones that were studied, the ones that were in the RCTs, in the studies that we have right now. So I'll propose to you a little roadmap today. So Act 1, we're going to talk a bit about the biology. Act 2, the gaps in clinic, in research as a geriatrician, the way that I see it for older adults. I'm going to give you a bit of a toolkit that might be useful if you're a researcher, if you're a clinician, if you're a healthcare worker. I hope this will give you a bit of an idea and a practical framework in the end. Okay, so if we talk first about the biology, I'm not gonna bore you with all the details of receptors and stuff, but mainly what we need to remember is that GLP-1 mechanism is beyond just glycemia. It's beyond being diabetes action specific. So there's an action on glucose-dependent insulin secretion, but also it slows the gastric emptying. It reduces the food intake because satiety is there. There's some impact on natriuresis, diuresis, and also cardioprotection with a major reduction of major adverse cardiovascular events, MACEs. And it also got an anti-inflammatory effect that we can see with this medication. In terms of appetite suppression, you have to keep in mind that with the effect, what will happen is that the caloric intake for somebody who is on GLP-1 medication will drop from 20 to 30%, which is what we see in the first studies and the first big RCTs. And the protein intake will fall proportionally. So if you eat less, you will eat less protein also. You'll see why it's important. And the GI, so gastrointestinal adverse effects, are there. So 44% of nausea, which is a lot, compared to 16% in placebo, some vomiting, and some discontinuation due to GI adverse effect also. So if we think about Mrs. O that I presented to you a bit earlier, she already doesn't eat that much. She lost 4 kilos. Is it a good idea? Maybe, maybe not. Let's continue. So what is being lost when you prescribe a GLP-1? So you see here the names of the molecules, and typically the most efficient of them is right now the tirzepatide, and you will lose between 15 and 22% of weight. So this weight, how is it? How do we divide it? I'm gonna show you afterwards, but let's say around 15% of weight loss that we can see with these drugs. And how do we divide it? In the studies, what we see in body composition is that it's mainly, yes, fat loss. The tirzepatide, for example, 75% of the weight loss is fat, but there's also a significant amount of lean mass loss. So lean mass includes muscle, but also bones and fibrosis in the DEXA, so it's not precise, but we know there's muscle loss right there. And it could go all the way up to 45% in older GLP-1s in a recent meta-analysis. So still a very significant dose, quantity, I would say, of lean mass that is lost in the protocols. To give you an image, when you get older, you will lose a bit of muscle. You will lose the equivalent of 0.5% that you can see here of lean mass in this figure. And if we look at the trials with the GLP-1s, it's the equivalent of 20 years of age-related muscle loss in the amount of a few weeks in the protocols. So it's a lot of muscle lost right there. And why is lean mass loss a problem or a red flag? The GLP-1 agonists do not directly cause muscle breakdown, but it's more of a consequence of the caloric deficit, the reduced protein intake that goes with it, the reduced mechanical loading also, because patients will have less activity and less weight that would stimulate all of that, and the rapid weight loss. So there's kind of an adaptive response of the body, adaptive catabolism that we can see. And if you're an older adult with that, it's kind of the impaired muscle protein synthesis with the fact that you don't eat enough protein. You don't have compensatory mechanism because the appetite is cut, so you won't eat as much as you need. And in older adults, you will see an anabolic resistance. All of that is kind of the holy trinity of lean mass catastrophe, I would say, if it's not taken care of. So just to give you an idea, because I was talking about sarcopenia and malnutrition, I just want to give you a bit of definition and lay of the land of what is sarcopenia. So there's a few definitions in clinical setting and research setting, and the most recent conceptual definition is the one that you have here from 2025. And basically, sarcopenia is a disease of the skeletal muscle that increases with age. That can be primary or secondary to something, and the definition can depend on the setting, on the age. So it's still a bit blurry with this new conceptual definition. But basically, if you have less, if you lose muscle mass, if you lose muscle strength and muscle-specific strength and performance, then you have sarcopenia. And the outcome of sarcopenia are known in the literature: impaired physical performance, mobility limitation, poor quality of life, mortality, all of that. We have numbers linked to sarcopenia. So there's an operational definition that is a bit older that is more easy to use, because it's this idea of if you have low muscle strength, low muscle quantity of quality, of low physical performance, then you have sarcopenia that can be severe. And these are we can see them with these tests that you might see in clinic or in research. So the famous grip strength with numbers with cutoffs for women and men. You have the chair stand, so it's when you ask your patients or your participants to sit down and stand up 5 times, and different tests of walking. So the walking speed also is a good way reference value and can help us diagnose the sarcopenia. Malnutrition is another beast. You can have overnutrition or undernutrition, and globally, when we talk about malnutrition, it's usually the undernutrition part. So I put that there's a lot of number, but just to show you that in all the consensus, loss of muscle mass or reduced muscle mass is always there linked to the diagnosis of malnutrition. So these concepts are interlinked quite tightly. And the prevalence of malnutrition goes from 5 to 10% in independent community dwelling seniors, all the way to 70% in hospitalized and institutionalized older adults. And of course, obesity is there, but malnutrition is linked to more mortality, morbidity, and diminution and less quality of life. So I was talking about malnutrition, about obesity a bit. That is more in the side of the overnutrition, but there's an overlap between that, and it's called sarcopenic obesity. So if I tell you, is this patient malnourished, and you see a very skinny, emaciated patient, you're going to say, yeah, of course, malnutrition. If I show you a patient that is well-rounded, actually, on the borderline of obesity, you're going to say, no, this patient looks fine. But probably this patient might not be fine and might suffer from what we call sarcopenic obesity. So if I give you a wonderful Wagyu steak, all marbled with the fat in the middle, you're happy. Wagyu steak, nice if you eat it, not nice if it's your own muscles. And this is what happens with sarcopenic obesity. You have infiltration of fat and fibrosis, and then the muscle doesn't work properly. And all of this concept was linked, like I said, to increased mortality, significant compared to just sarcopenia or even just obesity. So the both together has big impact on mortality and morbidity. And globally, around the world, 11% of population presents sarcopenic obesity, but in North America, it's more around 19%, like you can see here on the stats. So it checks out with what we see in clinic in our population. Okay, so if we talk, haven't lost you yet? Still there? Good. So if we talk now about the gap between what we have in clinic and why I'm being always careful and prudent as a geriatrician when I see a patient with a GLP-1, or if somebody asks me, should I start a GLP-1 with that patient? This is what I think about. The first point is that there's an obesity paradox in older adults. So in some observational studies, what we saw is that all-cause mortality in overweight between 25 and 29 older adults was like the mortality all-cause was associated with similar or lower mortality than normal weight older adults. So over 70-year-old, you might benefit from having a little bit of a reserve compared to a normal BMI, because BMI is not perfect as an indication of weight and health measure. And so it begs the question, what is the benefit of intentional weight loss after 75? And in the studies, it's quite unclear and understudied. And what is the weight goal that is appropriate in case of an older adult, or in case of even frailty? We're going to go back to frailty. And that's the big question that geriatrics is asking all the time. And we're fighting with our colleagues in internal medicine and endocrinology, because weight loss is not necessarily a good loss. And when you look at the trial, it's even more interesting because the majority of the trial would exclude the patients that we see with the most prescription of these medications. So the main trials, the mean age was around 46, 44 years old, definitely not older adults. They excluded a lot of type 2, type 1 diabetes, when there were obesity or even BMI that were less than that sometimes we see with our patients. A lot of females were in the trial. So is it very representative of the population we prescribe the GLP-1s? I'm not too sure. And the malnutrition were not clearly assessed. Frailty was never clearly assessed. So we need to be mindful of that before jumping in the GLP-1 train. And that's why it's the big question of who are the real world patients. First, who prescribed it? Specialists mainly, but primary care a lot. As a geriatrician, we're rarely involved in an initiation. Usually we stop it. That's what we do. And who receive them, there's a lot of people now receiving it. And as I said, they're older, frailer, more comorbid, because you want to tackle all those comorbidities that I told you about, in the heart, liver disease, and kidney disease. And the gap is mainly that there are no standardized frailty or nutritional screening required before initiation. I've heard stories here in the province of GLP-1 being prescribed on the phone, which is a problem. There's no single specialty that owns the monitoring after. They will prescribe it and then good luck after that. And the multidisciplinary approach is quite inconsistent. You will have clinics that are well organized with dietitian, kinesiologists, and all of that, and some that don't have the resources, or the patients are pretty, sometimes are very insistent. They want to try it and they want it because they want the perfect summer body, or their cardiologist told them it's the miracle drug for their heart failure. So the multidisciplinary holistic approach is not all the time there. And it's very important in vulnerable population because the impact of lean mass loss in vulnerable population is significant. If you're 30 and you lost some muscle mass, you can recuperate it with a proper training, proper nutrition. If you're 75 and comorbid, forget about it. It's going to be very, very tough, if not impossible. And if there is some sarcopenia at baseline, it's even worse. So who thinks about documenting functional decline, falls, slower gaits, activity of daily living dependency? Rarely documented when you initiate GLP-1 medication. And as I said, basically no studies on frail or malnourished patients. So what do we have in the toolkit? What can be helpful? What I think would be a good way to start something or to look at something? The first question you have to ask it is, who are your best friends? A big proponent of multidisciplinary approach. So your best friends are necessarily healthcare professional, like physiotherapists, kinesiologists, nutritionists, all of that, for a good holistic approach when you prescribe this medication, because it's not just a very targeted medication for a heart. As you saw, it has an impact on the whole body. And some screening tools might be helpful. Those screening tools could be the SARC-F, for example. It's a small questionnaire with 5 items. You don't need to be a geriatrician to ask those questions. And with the score, you can have a suspicion of sarcopenia and then confirm it with more investigation afterwards. And it's basically, are you able to transfer from the chair to the bed? Can you climb stairs? Did you fall in the last year? So very basic questions that you can ask. The mini nutritional assessment, very, very validated. 6 items, BMI, did you lose weight? How's your mobility? Are you stressed out? And with that, you can have a score on a malnutrition risk that you can address before starting a GLP-1. And if you don't have time for 6 questions, just ask the person, did you lose weight? Are you floating in your clothes? This is just basic questions, but are very high yield. The grip strength and the gait speed, low tech, higher value. That's the best thing that you can also do. Small dynamometer, or just making your participant or patient walk. You can have red flags then and know a bit where you're going, where you start, and what you have to look for. So I talked about sarcopenia, I talked about malnutrition, and said these are interlinked. And the last piece of the perfect storm, as I call it, is frailty. So when you have older adults, they accumulate deficits with their different concepts, different way to see the frailty. But when all of those are together, it really has a big impact on quality of life, again, and mortality. And this idea of frailty, that's why usually geriatricians are solicited, because it's kind of our area of expertise is evaluating that. But to simplify it for you, what is frailty? Basically, if you have a cat, a naughty cat that pushes stuff from the table, if it's your water bottle, you won't be really stressed about it because it's metal, it's going to fall, and you're just going to be annoyed about it, but you're not going to be stressed about it. If it's your wine glass, you might be stressed that the cat is pushing it, maybe because of the wine, but also because of the glass, and you don't want the glass to break when it falls down. So frailty is this lower physiological capacity, this vulnerability to stressor that you can see arise not just with age. Frailty and age doesn't necessarily link, but with the presence of comorbidities, the presence of different aspects of frailty. So when you age, you can stay robust. You can then go into the frailty zone and the danger zone of the disability for multiple reasons, because of external stressors, because of the physiological reserve that you have, and your biological life expectancy is different than your healthy lifespan that you will see. And frailty, there's many tools, many ways to define it, but it's basically this idea of vulnerability to stressors. If I have to summarize it in one concept. And frailty is not just one domain. It's not because you have a slow gait that you're necessarily frail. In 2026, frailty evolved a lot. It's multi-domain. It's yes, comorbidity, health status, cognition, nutrition, physical exercise. It's this whole evaluation, and this is why surgeons really like us, geriatrician, because we usually assess all that. Is it a good idea or not a good idea to operate? It's all of that we keep in mind. The other thing is, as a mentor of mine will tell me, Dr. Rockwood, he will say frailty is not destiny. There's multiple aspects of frailty that might be reversible. And the lean mass loss or the nutrition are clearly aspects that we can act on. Sometimes it's too late, but there's a part that can be reversible if we act in the right way. Okay, so we're now at last act, practical framework. I did a little bit of a decision matrix to think about the way, should I prescribe it? Should I start it? Maybe. What should I do with those GLP-1s? If you have somebody with a high BMI, but some frailty and so some comorbidities, it's a shared decision. Maybe you're going to need a multidisciplinary input with that. If they have a high BMI, but they're robust and function, it's kind of a reasonable candidate, but always with monitoring. If they have a normal or low BMI and frailty, but you want to prescribe it, let's say, for heart failure or for kidney disease, you weigh in carefully, because the lean mass that you're going to lose may not be renewable. You might not be able to bring back this lean mass, and you're going to have consequences for that particular patient. And if you have a normal or low BMI, but they're quite robust, you have to monitor carefully. So for me, what is a good GLP-1 prescription? It needs first nutrition optimization. Why it matters? Like I said, you will eat less with a GLP-1. It induces a lower, proportionally lower intake of protein, and protein is essential for muscle. So a dietitian co-management is default setting, not an option in patients and of more than 75 years old, 65 years old with GLP-1. So you won't see that frequently, but they're essential. Dietitians are best friend. We need this. The second aspect is resistance exercise. So there are no trials where they combined GLP-1 exercise in older adults. So there's a research gap right there. But in all the studies, the best evidence-based countermeasure for lean mass loss during caloric restriction is actually exercise. So you kind of need that to balance and to keep the muscle mass there. So the second co-prescription principle is that initiated GLP-1 without an exercise referral is incomplete in management, in my opinion. So a good prescription should always have nutritional assessment and exercise referral. And you're going to tell me, well, there's no resources. Of course, nobody's going to do that. But I think it's just a call to arms to actually give more resources for that, for prevention, and for healthcare worker in the multidisciplinary team to take care of patients holistically, and not just having a miracle pill to be skinny and to be unhealthy. The last one, a good GLP-1 prescription needs follow-up, adapting the prescription and deprescribing if necessary. As geriatrician, we're the pros of de-prescribing. We love it. Our pharmacist friends love it. We need to reassess urgently what are the red flags. Is when patients, they lose a lot of lean mass, their SART F is worsening at the review, a new functional decline. So when patients start to fall, start to be dependent, they have slower gait, it needs to ring a bell. And also when you have persistent GI adverse effects, also limiting the intake, you really need to think about that. So the big question is, how do I stop it? There are more expert consensus than real trials about that. Gradual dose reduction is fine, and so also revisit the indication. Why do we prescribe this? Is there another way, other medication with less effect that we can prescribe? And we have to reframe the prescription is not failure, is actually good medicine. The prescription, so if you prescribe a medication to a patient, it shouldn't be the same 20 years later, because your patient is going to get older, the physiology is going to change. You need a follow-up. Probably they're going to need the same dose for basic medication, but good medicine is actually having this follow-up and adapting, because older adults are not adults with a lower birth date. You know. Okay, so if I come back to Mrs. O that I presented to you in the beginning, with all the elements that you had in the case, before any prescription, as I told you, she lost weight, she's walking with a cane now, and not taking the stairs, taking the elevator. So regardless of the GLP-1 decision, she needs a referral for nutrition, she needs a referral for physical activity, progressive resistance, fall prevention, all of that. It's the first step when we see that kind of lady. The second is actually to revisit the indication. Do we really want a weight loss in that patient? Is it because her heart failure is not well managed? Is it why we want to do that? And what is the objective? Cardiovascular risk reduction, or can we address it another way? So talk properly with that patient and also with the colleagues to have a plan that is good for Mrs. O. And if you initiate the GLP-1, it's the motto is always start low, go slow, like in the Bears criteria. So the lowest effective dose, monthly monitoring if you can, or close monitoring, and also predefine stopping criteria before the first injection, and adapting what she has as a medication for her diabetes. So the answer is not never GLP-1, it's maybe not yet, or not without a plan. So I don't want to demonize the GLP-1. On the contrary, I think they're great medication, but they need to be prescribed mindfully. They need to be used mindfully, not just as I say, as a miracle pill to lose weight. So in terms of perspective, so we've established all that. GLP-1s carry a real under-recognized lean mass and nutritional risk. The trials exclude most of the patient that will have the prescription, and there's some geriatric tool existing that can be integrated in different settings, research or even clinical. But there's still, like I said, the evidence in research. We don't have good trials in sarcopenic, frail, or malnourished patients. We don't have a good monitoring protocol and body composition in older users right now, and no consensus threshold for unsafe lean mass loss. So I would put on the research agenda having good trials with GLP-1, protein and exercise combined, or GLP-1 alone in older adults, maybe some observational cohorts with the frailty trajectory in real world GLP-1 users, interdisciplinary consensus on screening and monitoring with other healthcare provider, other specialty, to have a clear path there. So I think there's a lot of research to be done in that area. So as the take-home messages, so we'll have a bit of time for questions and discussion. What I presented to you today is that GLP-1s were not tested in the most at-risk patients, the frail ones, the sarcopenic ones, the malnourished ones. Lean mass loss is significant and important and potentially irreversible, so it needs to be well tracked. And tools exist for screening, and there's those three elements of a good prescription of GLP-1, namely the nutritional support, exercise support, and the follow-up and deprescribe it in case of a problem. And how to preserve the lean mass, as I said, The protein intake, I just put some numbers as a reference for you. Some resistance training through physiotherapists, kinesiologists, even low volume resistance can help maintain the lean mass, slower titration of the medication, and monitor closely those at-risk groups. And with that, you can reduce the loss about 10 to 20% just with those measures applied, which is significant, as you saw in the numbers, with at the 45% at max muscle loss. So it's very, very important. So I want to thank Dr. Moret, who helped me during my postdoc, and I learned a lot from him and from Dr. Rockwood, the chaire de recherche sur le vieillissement, who financed my postdoc last year on nutrition. And thank you again to the St. Mary's Research Center for inviting me today. So thank you.
I'm sure there's a lot.